Καλησπέρα κυρίες και κύριοι και καλή Κυριακή. Απόψε είμαστε κοντά σας με άλλο ένα θέμα υγείας ενδιαφέρον και είναι η αρχή μιας σειράς θεμάτων που θα σας παρουσιάσουμε τις επόμενες εβδομάδες. Έχω έναν ιδιαίτερο καλεσμένο απόψε, τον Mr Ramon Tahmassebi. Είναι ορθοπαιδικός, είναι χειρουργός και θα πω στη συνέχεια λίγα λόγια για αυτόν. Είναι μέρος της ομάδας του London Sports Orthopaedics. Είναι μια μεγάλη ιδιωτική κλινική στο Λονδίνο και αποφασίσαμε πριν αρκετούς μήνες να κάνουμε μια σειρά παρουσιάσεων για διάφορα ορθοπαιδικά προβλήματα. Θα ξεκινήσουμε από όλες τους μεγάλους συνδέσμους και αρθρώσεις, θα μιλήσουμε για τους ώμους, θα μιλήσουμε για τον καρπό, θα μιλήσουμε για τα ισχύα, για τα γόνατα, για τη σπονδυλική στήλη. Οπότε θα έχουμε μία σειρά περίπου 6 επεισοδίων, κατά τη διάρκεια των οποίων διάφοροι ειδικοί από την κλινική θα μας μιλούν ο καθένας σε ό,τι είναι εξειδικευμένος και θα μιλήσουμε για προβλήματα που βλέπουμε κάθε μέρα, αυτά που συνήθως μας ρωτούν στο ιατρείο και αυτά που απασχολούν πάρα πολλούς ανθρώπους. Πονάμε. Πονάνε τα χέρια μας, πονάνε τα πόδια μας, πονάει η μέση μας, δεν ξέρουμε γιατί πονάμε. Ποιος είναι ο λόγος που πονάμε, ποιες είναι οι πιθανές αιτίες, τι διαγνώσεις μπορούμε να κάνουμε, τι διερευνήσεις, πώς θα θεραπευτούμε, πότε φτάνουμε στο χειρουργείο, όλα αυτά. Θα προλογίσω τον καλεσμένο μου και θα ξεκινήσουμε τη συζήτησή μας που ελπίζω να την βρείτε εξαιρετικά ενδιαφέρουσα όπως την έχω βρει εγώ, επειδή έχουμε κάνει και μια συζήτηση πριν βρεθούμε. Dear Ramon, welcome to our TV show.
Thank you very much for inviting me, Kiki.
Sorry for the Greek, but it's the Greek introduction.
No, of course, it's necessary.
It's the easy part.
Of course.
So, Mr. Ramon Tahmassebi, it's a hand, wrist and elbow specialist, orthopedic consultant. He's trained in London, UK, and he's also an NHS consultant at King's College Hospital, the prestigious one. My first job in London was there.
Oh, really?
I can tell you, yes. And he's also a private consultant at London Sports Orthopaedics. I said a few things in Greek about that big clinic.
Yeah.
You are a group of specialists, you do a fantastic job, and each one of you has his own bit where he's practicing, he's very good, and he knows his job very well, operating, investigating, helping. And today, I think you will tell us quite a few interesting things.
Thank you. Yeah, so thank you for having me along. So you're quite right, London Sports Orthopaedics, we're a group of not just orthopaedic surgeons, but also sports and exercise medicine doctors. And as you've correctly described, we have people who subspecialize in practically every section of musculoskeletal medicine and surgery. So I'm a specialist in the hand and wrist mainly, but also we have specialists for the shoulder, the hip, the knee, foot, ankle, spine, and we also work with sports physicians, and we treat everybody really. We treat sports people, young people at all levels, and we also treat people from all ages, and especially some more old people who have musculoskeletal problems from an arthritis point of view. So we don't focus solely on sports, but that's a major part of what we do.
That's wonderful, because you see, a lot of people, really a lot of people, and that's why I was very keen on doing these episodes with your clinic. A lot of people complain of pain. We have more and more people who suddenly develop pains, musculoskeletal pains, people who exercise a lot and they have some traumas, people who dance a lot and they get pains and tears in soft tissue. We see such a variety of things, but I'm very happy to have you here tonight to discuss about hand-wrist problems, because they're quite common.
Yes.
And I would like to start, I have a lot of questions for you, I'm afraid, but let's start with causes of hand pain. We see quite a lot. I will ask you, from my experience, what I see, and I would like to clarify a few things and stealing from your knowledge and experience, but I would like to start discussing causes of hand pain, which are quite frequent lately.
They are. So along the lines of what you've already described, musculoskeletal pain is more common, and I suppose that's mainly for a couple of reasons. First of all, overall the population is becoming older, but as an aging population we are living longer, and people are more active than they used to be. So we're seeing a great deal more arthritis and things along those lines. At the other end of the spectrum, there is now a very huge trend towards sporting activity in the young. And that's maybe changed over the past 20 or 30 years, certainly in the UK. And people are much more engaged with their health and sports and looking after themselves, and as a result, they injure themselves during sporting activities. So in terms of pain in the hand and wrist, I suppose you could start to break it up into two groups. People who have sporting injuries, who are younger, but actually perhaps what we will focus on is not necessarily sports injuries for this discussion, but actually some other causes of pain in the hand and wrist. So one easy way to break it down is to talk about neurological causes, and that's probably where we should start. And one really common problem that affects a great number of people is carpal tunnel syndrome.
Very common, yes, thank you.
Shall I explain a little bit about carpal tunnel syndrome and what it is?
Yes.
So carpal tunnel syndrome is a very common condition that affects people's hands. It can, in theory, affect people of any ages, but it tends to affect people who are perhaps middle-aged or perhaps even the older population more commonly.
Okay.
It's a problem that's caused by dysfunction of a nerve. The nerve in question is called the median nerve, and it travels a very long path down the entire length of the arm. But as it goes from the forearm into the hand, it passes through a very narrow passage, a tunnel, just at the level of the wrist. And as it enters this tunnel, it's a site where it can become compressed. And then the compression of this nerve can lead to symptoms in the hand. And one of the classical symptoms is pain. The nerve that's pinched and squashed reacts. And so people experience pain, which is sometimes hard for them to describe, but seems to mainly affect the fingers of the thumb, index, middle, and sometimes the ring fingers. But it can actually affect any of the fingers. And as a result of this dysfunction, not only is there pain, but sometimes there are sensory disturbances as well. People often complain of pins and needles, numbness, tingling, or sometimes electric shocks. And they also report sometimes functional problems. So they have difficulty perhaps with tasks which are fine, such as maybe putting on jewellery or a bracelet, maybe picking up a small object or doing up buttons.
Okay.
They can also complain of loss of coordination, and weakness in their hand as well. They feel that sometimes their thumb is weak, and that's because this nerve sends signals to the muscles around the base of the thumb, and of course if those signals are being interrupted, the thumb feels weak, or the fingers can feel weak as a result.
Yes, that's very common indeed. And how do you usually investigate that? A lot of people come, they describe symptoms, you don't know where to send them first. So what would the specialist would say? What would the specialist say? Where should we go next?
Well, the first thing that would be required is to establish the diagnosis, and the history that people give, as I've described, is really, really classical. Other things that make it more likely to be carpal tunnel are the time of day at which it occurs. So, for instance, people often have problems at night time. They're woken at night time by pins and needles or tingling. They have to wake up and shake their hands before they can go back to sleep, or dangle their arm over the side of the bed. And that's very typical, very classical for the history.
You worry me, it happens to me sometimes.
Oh dear, you should come and see me afterwards, and we'll take a look, we'll investigate.
I'm safe now.
Then there are one or two other, I suppose, risk factors or associated conditions, and as a result of the history, we then move on and try to identify whether or not there are other associated risk factors for the development of carpal tunnel. We know that carpal tunnel seems to affect people who are a little bit overweight. So your body mass index has got a direct correlation to the development of carpal tunnel syndrome. It's not to say that all people who are overweight develop carpal tunnel syndrome, that's not true, but high body mass index is definitely associated with the development of carpal tunnel syndrome. Sometimes other metabolic conditions, such as reduced activity in your thyroid, can predispose you.
I would ask.
And so hypothyroidism is perhaps an under-recognized cause of carpal tunnel syndrome. And I think 1 or 2 studies have shown that if you take a group of people in whom you suspect carpal tunnel syndrome, they may not exhibit definite signs of an underactive thyroid, but if you were to test their thyroid with blood tests, you may find a degree of underactivity in a lot of those people in whom you wouldn't ordinarily suspect it.
Okay.
It can occur in various age groups. It can affect young people and old people. One other particular group of young people whom it can affect are pregnant ladies. And that's because of the hormones and the way that their bodies retain fluid. And actually, it causes the nerve to become compressed as it passes through this tunnel, and that's mainly due to the amount of fluid within the soft tissues that can in turn cause a secondary compression or irritation of the nerve. For some people, we never really identify a definite cause, but if we go back one step, another metabolic thing that we should really discuss is diabetes. And of course, diabetes is one huge, I suppose, risk factor for the development of carpal tunnel syndromes, but also other nerve problems that affect both hands and feet, what we refer to as neuropathies. So sometimes we have to distinguish whether or not this is a carpal tunnel syndrome caused by a very specific compression. We have to try and distinguish that from dysfunction of nerves globally as a result of diabetes. So after seeing a person who may have carpal tunnel syndrome, based on their description of how the symptoms manifest themselves, then we would see, are any of these things potentially treatable or reversible? So for instance, hypothyroidism, weight loss, good management of diabetes and bringing blood sugars down. In order to diagnose carpal tunnel syndrome, that's sometimes all we need.
The history. The
history, and that forms a fantastic platform, and then you can go on and do a clinical examination without having to do any specific investigations. When we examine someone's hands during our workup for carpal tunnel, the first thing that we would do is we would determine whether or not they have a normal appearance of their hands. People who have had long-standing carpal tunnel have wasting of their muscles, especially around the base of the thumb. And I have a picture in which this is really clearly highlighted, and you can see that in this picture here, you will see that this person's thumb looks very weak. And this is a very late stage carpal tunnel syndrome. The muscles have really wasted away, and you can actually see a cavity where the muscles used to be. We may sometimes also see that the hand muscles in general look somehow withered or weak, especially around the index and middle fingers. The next thing that we would do is assess sensation. So we ask patients whether they have normal sensation in the area that this nerve works in. So that's classically the thumb, index, middle, and usually half of the ring finger. So we would compare one side to the other, but of course if both sides are affected, then it could well mean that it's difficult to distinguish a difference. Then we would ask to test power, and again we would test the power of a specific nerve muscle in the thumb. And then we would do certain tests in which we would try to provoke the nerve into becoming irritated or sending electric shocks or signals down into the fingers. And one thing that we can do is we tap the nerve just as it passes into the carpal tunnel. This slide here can show exactly where the nerve passes inside the hand, and as it passes beneath this band of tissue in the carpal tunnel is where it becomes compressed. And if you tap on the nerve that's irritable and being squashed beneath this piece of tissue, it can send shooting signals or pains or electric shocks into the fingers. And then similarly, if we press on the nerve in this area where it's most irritable, perhaps after a minute or so, these fingers will go to sleep and they'll feel very numb. And that's, again, really quite strongly indicative of carpal tunnel syndrome.
So that's not a difficult examination to perform, even in clinic, even from a non-specialist?
Absolutely, yeah. And many people like yourself who are really familiar with carpal tunnel syndrome will see lots of people in their clinics, and actually just through these key factors of the history and how they present, 1 or 2 visual signs within the hand, especially the wasting around the thumb, plus 1 or 2 easy tests to undertake in the GP surgery.
Yes.
And actually you can really develop a very, very clear picture of carpal tunnel syndrome and make a really firm diagnosis without really having to do a great deal else. For some people it's not so clear-cut. Maybe the symptoms don't always fall into that category where they're readily recognizable as carpal tunnel syndrome. Maybe the anatomy is different and people sometimes have problems that affect these 2 fingers rather than the thumb side of the hand. Thank you. Sometimes people exhibit some symptoms which don't necessarily make it convincing initially that it's carpal tunnel syndrome. So for those we would investigate them further, and certainly one thing which I use from time to time are nerve conduction studies.
Yes, that's the most common we request.
So in a nerve conduction study, what we try to establish is how quickly the nerve conducts electric signals. So we would assume that the conduction of the nerve is normal along its path, but is abnormal in the area where it's being pinched or compressed. And so by placing electrodes at various points along the arm, and in particular across the carpal tunnel, we can see if the speed of conduction is reduced around this area, which again would be very supportive of carpal tunnel syndrome. The benefit of doing this is that sometimes we end up looking at other nerves in the hand and wrist and arm as well, and it gives us a much more global picture of whether or not this is carpal tunnel syndrome in isolation, whether there are other nerves that are also being compressed, and on occasion whether or not the problems that we're seeing in the hand are coming from here or perhaps coming from higher up, whether they're coming from the nerve being pinched at other sites in the arm, sometimes around the elbow, but that's much less common. And for some people who have neck problems in particular, the nerve roots all the way up in their neck can become pinched, yeah, absolutely, just through arthritis, through disc problems, and then that can lead to a slightly different set of symptoms, but it can certainly mimic carpal tunnel syndrome.
That's very interesting. What about MRI? Will that give us any information?
MRI is certainly very useful when looking at the nerves in the neck. And if you're certainly suspecting that there is a problem that's arising from the neck, so sometimes people will come along and they have very specific neck pain,
yes,
or they will have global problems that don't just affect their hand but maybe affect the muscles of their arm and forearm also, then under those circumstances an MRI of the neck is extremely useful. If you're suspecting a nerve that's being pinched around the elbow, MRI is very useful. Modern MRI scanners can be incredibly sensitive and they can pick up an amazing amount of detail, and it's very possible to see nerves on MRI scans, especially larger nerves, and in particular this nerve is visible on MRI scanning. Sometimes you can also undertake an MRI scan of the hand and wrist and see the nerve and be able to identify if there is a significant compression of it, difficult to pick up subtle ones. But also the benefit of an MRI sometimes is that it can help you to identify other causes or other problems of pain within the hand, so that you could potentially rule in or out another cause if you suspect one.
Bony cause, mainly?
Well, sometimes one other thing that can predispose you to the development of carpal tunnel syndrome is whether or not you have some arthritis. So quite often people who have arthritic hands or an arthritic wrist can then develop carpal tunnel syndrome. So it helps you put the two together. Sometimes it can help you identify other causes of pain. You may not necessarily need an MRI scan for that. You could certainly do it with an ordinary X-ray. And of course, you know, you can organise that from many places rather than a specialist centre with an MRI scanner. But what happens is that the ligament beneath which the nerve passes can become thicker, and it can pinch on the nerve, and that seems to happen in certain people who develop arthritic problems in their hands. So the two do go hand in hand, if you'll excuse the pun.
Excellent. And what options do we have? Is it surgery directly, or do we have other stages before getting to the theatre?
Well, actually, there are many. There's a whole spectrum of things, and maybe at one end of the spectrum, you can choose to do nothing. Sometimes people come along and they say, look, I have problems from time to time. I'm not sure what it is. It doesn't really bother me, but I thought I would get it investigated. You say, look, it's probably carpal tunnel. And they say, fine, I just needed to know, and we don't have to undertake any further investigation or treatment, but we can observe that person, see them again perhaps in a few months to ensure that their problem isn't becoming worse.
Mm-hmm.
People who have milder symptoms, or people who have symptoms particularly at night time, quite often benefit from a splint. And here you'll see a picture of a splint, which will just demonstrate the fact that the hand can be kept in a relatively comfortable position. Now, the way in which the splint works is, if you imagine that the nerve is traveling in a straight line across the wrist, sometimes as we sleep, the wrist and the hand can fall into unusual positions. And as a result, it can cause the nerve to become kinked, or sort of the route that it takes is not necessarily straight.
It doesn't relax during sleep, it doesn't rest, literally.
No, I mean, the nerve is still functional, it's still working, but actually its position is well maintained within the splint. And one of the tests that we do, if we're going to provoke the nerve, is we can actually place the wrist into this flexed position. Now, if you take someone with bad carpal tunnel syndrome and you ask them to do this, after a couple of minutes their fingers will go numb. So quite often this happens just accidentally during their sleep. And then the splint will help to prevent that happening and keep their wrist in a more comfortable posture, and that helps with their nocturnal symptoms.
I see.
Then beyond that, there are a couple of things that we can do. So again, we talked about how the reversible causes should then be addressed. So hypothyroidism, diabetes, weight, sometimes issues involving pregnancy. So once you have reversed all of those things and you've made the person as well as you can from a metabolic or hormonal perspective, especially with regard to diabetes, the next thing that we can sometimes do is offer people an injection.
Steroids.
Yes. Now, the way in which these work is that, as you will see from this other picture, as the nerve passes into the tunnel, the nerve is not the only structure in the tunnel. The tendons that arise from the muscles of the forearm follow the nerve into the tunnel and then continue into the fingers. And if you imagine that the swelling around the tendons can sometimes enlarge and increase, and if that happens, it means that the nerve gets squashed against the boundaries of the tunnel. Also, the nerve itself has a lining which can become inflamed as a result of pressure or irritation, and so the action of the steroid is to act as an anti-inflammatory.
I see.
And so what it does is it reduces the swelling around the tendons, and it relieves indirectly the pressure on the nerve, and it can also release or reduce the swelling around the lining of the nerve itself. This is a pretty good thing to do for many people because it can be done in a GP surgery, it can be done in a doctor's office, in a clinic, and it's relatively quick, easy and safe to do.
And it's the most common, I think. From what I see, it's the most common choice of treatment.
It is, and actually most people who do have carpal tunnel syndrome will respond well to an injection. It will improve their symptoms for a variable length of time, but sometimes people have an improvement for 1 year or more. From our perspective as doctors treating carpal tunnel, it's also quite useful because if people have a diagnosis which is sometimes equivocal, and then we inject them around the carpal tunnel, if their symptoms improve, it lends weight to the diagnosis because we think, yes, it could be carpal tunnel, we've injected the carpal tunnel, they have improved, and that helps us to become more confident. If we inject the carpal tunnel and their pain is no different, and actually the symptoms remain unaltered as a result of the injection into the carpal tunnel, it might sort of be a wake-up call for us that maybe we should think along other lines and do some other investigations to look for another cause. So some people manage to avoid the problems with related to carpal tunnel for a long, long time with yearly injections.
Yearly. I would ask you how often you can do them.
I would say that I'm very happy to inject people who do have a problem that they don't wish to leave, that does bother them at night time or during the day, that does bother them at work or when they're doing certain tasks, and it's quite intrusive in their lives, whether recreationally or professionally. Those people who also feel that their symptoms don't merit surgery or they don't want an operation, and that's quite a few people actually, so they're very suitable for an injection. Now that can be done in the doctor's office, but also it can be done with an ultrasound scan. And the ultrasound is useful, it helps us to guide the needle into a really accurate location. And sometimes with the ultrasound, we can see that the nerve is being squashed and pinched. It has almost what we call a bottleneck appearance. So in the band across the wrist where it's being squeezed, it actually looks a bit thinner. And again, the ultrasound can help us identify other causes. For instance, if there is particularly bad inflammation in the tendons, and helps us identify things which are again treatable and reversible. So most people who do have real carpal tunnel then do get better. And I would say that if someone else were to come back, let's say after 1 year, and request another injection, I would be happy to discuss that with them. However, I think if people come back on repeated occasions, on 2, 3, 4 occasions requesting injections, I would certainly be inclined to discuss surgery with them. And also, if they were to be injected, but then their symptoms were to recur very quickly, and let's say they come back after a few weeks or a few months and say, yes, it worked very well, but it really didn't last very long, I would probably think twice about re-injecting them. I would probably also think that they could be suitable for surgery.
So that was very clear about the carpal tunnel syndrome. Do you want to tell us a couple of things about the surgical treatment? Because that's your main specialty, actually.
It is, sure. So surgery for carpal tunnel syndrome is actually very common. And many patients who go through the process of investigation, treatment, will end up actually having surgery. Not everybody, but a significant number. And on the whole, it's a very successful and safe procedure. The aim of surgery is to relieve the pressure on the nerve. So that's achieved by making a small incision here at the base of the hand, just at the where the wrist really meets the hand. And the incision is fairly central. And we divide this tight band of tissue that sits on top of the nerve. And in doing so, we take the pressure off. So in many respects, the nerve still has to intrinsically recover. We have just taken the pressure away from it. So what we do in the surgery is effectively give it the best chance to recover. So that may not happen immediately, but for most people it will happen over a course of weeks or months. The procedure itself takes about 15-20 minutes to do. It's often done under a local anesthetic. Patients come and they have an injection in their hand. It makes the area go numb. They have surgery and they go home the same day with a bandage. And then usually after a few weeks, the wound has healed. People get back to a high level of function afterwards. Complication rates are very low. And because we've been doing carpal tunnel releases for many, many years, there's a lot of data available on how people do afterwards. And actually the overall complication rate is quite low, and the success rate of the operation in relieving carpal tunnel syndrome is actually very high. So it's a successful thing to do.
And it sounds quite simple. And the fact that you have local anesthetic, small incision, stitches, not leaving a big scar, going home after a few hours. And how long do you usually have to stay off work? Recovery period?
So it kind of depends. Most people who are in an office-based environment will probably be back at work within 2 weeks, once the wound has healed.
Reasonable.
Yeah, and it's really just to do with the wound being healed and then being able to use a keyboard or a mouse. I think that if you're in a more manual job, then it may take a bit longer, simply because people have soreness here in the palm, and it can be difficult to make a full tight grip if you're lifting heavy loads or if you're carrying heavy things. It might take you a little bit longer to get back to a manual job that's quite demanding, possibly up to 4 weeks or even longer, depending on what people do. But for the purposes of getting back to an office-based environment or being able to look after yourself at home, I would say usually 2 weeks is a fairly good ballpark
Very good.
to be able to just get back to a basic level of activity.
All right. That's very interesting. And you make it sound so simple, and it's very nice the way you describe it. I think even if somebody doesn't know anything about medicine, it's very easy to understand. And that's the purpose of this show we do, trying to inform people. And it was very nice the way you presented it for me as well, so I'll know how I will examine my patients next time they come to me. It's kind of teaching for me, you know?
Well, yeah, very good.
That's very challenging for me doing this program. Anyway, shall we discuss other causes of hand pain? Because I'm sure you come across a lot of osteoarthritis, rheumatoid arthritis, tendonitis, fractures, all these things. So I'll leave it to you to choose the ones you think that are most common and most important, and to present them in your own way.
Well, I will leave the sports injuries and the fractures to one side, simply because people often realise that they have sustained an injury. So there's no great mystery in many respects. Obviously, if you're a sportsman or you've fallen, or perhaps you're an elderly person and you have fallen and you've landed on your wrist, obviously you have immediate pain and there would be a concern regarding a fracture. And so, because that's a very direct route often to a doctor, whether it's to your GP or whether you go to an emergency department, so people have a very well-established route towards figuring out what the problem is. Perhaps we could talk about some of the less established routes, because quite often people have chronic hand pain without a history of injury, and they're not really sure as to what the causes are, what the solutions may be.
True.
And you're quite right. Arthritis in the hand and the wrist is a very common thing. We place huge demands on our hands. Maybe sometimes we take them for granted. But it's definitely true that lots of people develop arthritic and degenerative changes. Now, we can start at the fingertips and work our way up. What you'll see in my next slide is an illustration of arthritic fingertips, and how the joint, not just at the fingertip, but lower down, can become very swollen, painful, they can lose function, and as a result, people can be quite badly disabled by these changes.
True.
So especially the elderly, and if all of a sudden you lose your hand function, you can very rapidly lose your independence, the ability to look after yourself, to look after your spouse, your husband, your wife, or perhaps to look after your children or your family, if you find it difficult to do simple things such as wash yourself or dress yourself or care for yourself or another, or even things like cooking, cleaning, carrying, shopping. And soon, even small problems can become quite debilitating. The nature of disability in the hand as well means that even though you may have a single finger affected, or perhaps your thumb in isolation affected, it means that your hand function globally can become badly affected. So for instance, someone who has arthritis at the base of their thumb can really feel that the hand function has been lost, and they can do very, very little for themselves under these circumstances, even though the remaining fingers may be okay. If we go from the fingertip down, we see that in this picture here, for instance, the finger joint becomes swollen, sometimes red, hot, painful and stiff. Solutions for that may include simple things such as splints or supports, may include sometimes injections, may include simple painkillers, and there are some surgical options involved as well. If we look at the next slide, we see that the next joint down, called the proximal interphalangeal joint, can often become arthritic, inflamed and somewhat deformed. But now we're developing much more interesting ways of treating these problems. You could see in my slide here that actually in this person who had bad arthritis of the joints in these two adjacent fingers, I've undertaken a joint replacement. So in a very similar way to a hip replacement or a knee replacement, we can now undertake joint replacements for small joints in the hand.
I have never seen that. And what material is that?
Well,
because it's the flexion and the movements which are more, fine compared to the hip.
Well, funnily enough, the materials and the technology are almost identical. So what we do is we take away the surfaces of the joints which have been worn away, they lose their cartilage. And as a result of losing the cartilage that covers the surface of the bones in the actual joint, the loss of cartilage leads to arthritis. And that's what causes pain. So what we do is we remove what remnants of cartilage there are, and we replace those bearing surfaces of the joint with an implant. And as you can see in this particular case, the implant has a stem. The stem sits within the bone, and it can sit on either side of the joint, so one on one side, one on the other. And the stems are often metallic. Sometimes in the hands they can be made of carbon. So yeah, then
so many new things.
Many, and then the area, the articulation where the movement occurs, is variable. It can sometimes be metal on metal, a very smooth, polished metal, or it can often be a plastic on metal. And of course, the carbon ones articulate as a very low friction articulation, carbon on carbon. So there's lots of different options and many different manufacturers, many different implants. There's yet to be any consensus on which one is potentially the best, but we're seeing increasing success from these. Similarly,
amazing.
If we take a look at this next slide, you will see that this is now an option for the thumb. Arthritis at the base of the thumb is a really common problem.
And it's the worst, actually.
It's so disabling.
They complain, yes, it's exactly, very disabling.
It's really disabling for people, and it seems to affect some groups more than others. Now, you've already mentioned that perhaps ladies, and they don't necessarily have to be old. I see quite a few young ladies who develop these problems, and they're ladies in their 40s, who then just progressively develop worsening problems in their 50s, 60s and 70s.
After menopause, I think it's worse.
It
I
could
don't
well
know
be, yeah.
what you have observed from your experience, but for some reason I think it gets worse after menopause.
Yeah, and that's true. And there are some associations between the hormonal aspect of it, as well as the age aspect. And so, for instance, we know for a fact that in the feet, bunions are much more common in women than men.
Yes.
And again, this may be sex-related, hormonally related in some way. And
or they accuse our shoes and the heels.
Well, so then this is obviously an environmental factor. But perhaps there's a link, and maybe there are associations, and maybe that's why women are more prone to developing arthritis at the base of the thumb. It's probably to do with ligamentous laxity. I think women, generally speaking, historically are more flexible, so they have stretchier ligaments, and that may predispose them to developing certain types of problems, such as arthritis in the base of the thumb. And so arthritis of the thumb, very common, very debilitating, can be very painful and lead to a significant loss of function. And funnily enough, just like carpal tunnel, the treatment pathway is almost identical. So for instance, at one end of the spectrum, we may choose to do nothing. For someone who has very mild symptoms and doesn't feel that it's particularly intrusive. Next, we can support the thumb, or perhaps support the joint, which is arthritic, so that we use splints to try and minimize the movement, minimize the forces going through the worn out joint. We can also think about doing injections. And again, maybe like the carpal tunnel injections, they're quite useful for reducing pain or symptoms. But for a lot of people, the symptoms recur. The injections help to buy time and dampen down the inflammatory response and reduce the pain. But the arthritic process is still ongoing, and for many people, they end up returning. And of course, at the end of the line, they will perhaps come and see a person like myself or an orthopaedic surgeon who deals with arthritis, and you look at surgical options. A very common surgical option for the thumb is a procedure called a trapeziectomy. If I show you another X-ray here, in which we see that the thumb bone, called the metacarpal, sits on top of a smaller bone called the trapezium. And that's usually the most common site for arthritis at the base of the thumb. A very good, very successful operation that we have historically done for this is actually to remove the trapezium. And as we do so, it means that one side of the arthritic joint has now been removed, so it's a very good, very reliable way of treating pain. Patients often become somewhat alarmed by the fact that we are removing a bone.
Exactly.
And they wonder what happens to the space and the gap.
Exactly, I would ask you.
Actually, it fills in with a very dense, fibrous, thick scar tissue.
Oh, okay.
So even in the most simple form of this operation, all we do is we remove the bone and we put in some tight stitches to close the space where it used to sit, the gap. And that in itself is a very successful operation. There are other variations of the same procedure where we remove the bone, and to prevent the thumb metacarpal falling back into that space, we can borrow adjacent tendon from the forearm, and we can take a strip of tendon and weave it around the base of the metacarpal bone to either form a sling to prevent it from falling back.
Amazing.
Or we can drill it through to provide a kind of an anchor to prevent it from falling back into that gap.
Amazing. That's kind of art. To take tendon, to put it around the thumb, to hold it there, because actually, likewise, you maintain the movements, the mobility and the flexibility.
Absolutely. So the aim is to try and retain the movement and flexibility and improve the pain, but not compromise anything else. So we only take tendons in such a way that we don't disable another part of the hand or wrist function. And
it's a tiny strip you remove, I suppose?
Well, there are so many variations actually. So usually most people who do use the tendon method will take 50% of an adjacent tendon that sits here in the forearm. You could, if you choose to, take 100%, and actually that tends to work quite well as well. But then finally, the other option for the base of the thumb, as you will see from this x-ray that I showed earlier, is actually the fact that you can now do a joint replacement in a very, very similar way. And if
even for the thumb,
yes.
It sits here. So when you put that metal implant, it sits between the bone
picture.
and
yes.
Oh, okay. And where does the second part insert?
Well, it effectively works like a hip replacement. So there's a ball and there's a socket. So what we will see is that it's
a screw.
A stem sits inside the metacarpal. Attached to that stem there is a ball. We keep the bone beneath, the trapezium.
Yeah, okay. That's where it sits. Okay.
It sits there, and we create a cup that we insert into the trapezium. And so it acts like very much like a mini hip replacement with a ball and a socket.
It looks like a bit.
It does, yeah. And actually, obviously, in terms of joint replacement, the hip and knee have got many years of history behind them. They've been developed for decades now, and we borrowed a lot of the technology and the knowledge from hip replacements in how we now design, manufacture, and insert implants in the hand and wrist.
May I ask you two simple questions? Because I'm a doctor, but the viewers are not doctors, most of them, so I try to guess questions they might have. This metal implant, is it a problem in future investigations such as MRIs, or when they travel and they have to inform about metal implants, or are they so minimal which wouldn't be a problem?
So when an implant, metallic implant, is very well bonded to bone, and what happens in the weeks and months and years after the implant is inserted, the patient's own native bone grows onto the implant and it becomes very well bonded.
I see. So
in these circumstances, when an implant is well bonded to bone, there's no real risk from an MRI scan.
It's like being absorbed, let's say.
Well,
in a simple way.
Well, yeah, so
it becomes one.
It becomes one. So the bone cells can literally grow onto the surface of the implant and attach themselves onto the implant. So it becomes a very well embedded structure. So if you go into an MRI scanner where there is effectively a very big magnet, there are no real risks.
Nice.
In terms of going overseas and going through scanners, airports, it's a very common question. I think that on the whole, this is not a huge amount of metal. And of course, because now we implant much bigger bits of metal inside people's hips all of the time, inside people's knees, people who have fractures and we fix them with plates and screws. osteosynthesis. The modern metal detectors are sometimes very clever, and they will not necessarily pick up these things. They're looking for different things. And now, of course, we have X-ray machines that we pass through. Have you been through an X-ray machine yet in the airport?
Yes, I did.
Yes.
Recently.
Yeah, so they're becoming increasingly common.
Yeah.
And then, of course, you no longer need to distinguish between certain types of metals, because the X-ray will show you, oh, this person has a joint replacement in their hand, hip, elbow, knee, or whatever. So I think the technology is very much keeping up with all of the variations.
And a very critical question, are these treatments available on NHS or only privately?
No, they're all certainly available on the NHS. Yeah.
Amazing.
And in fact, all of the X-rays that I have shown you today of joint replacements in the hand, and I have one more to show you of the wrist,
yes,
they were all in my NHS patients.
That's very promising for the patient. That's a very, very positive thing to mention, because people want to have something special. They are seeking for advice, for help, for permanent treatment, and most of us believe that NHS will not provide that much. The fact that they provide such treatments, it's absolutely amazing.
Yeah, absolutely, and I think that one of the core principles of the NHS is to not necessarily, I think you have to provide cost-effective treatments.
Correct.
And perhaps all of these things that we're talking about now may not be suitable for everybody. And don't get me wrong, sometimes the cheapest treatments are the most successful.
I agree with you. Because sometimes people want to do it privately. They think they will get better care, better materials, or I just don't want to be on a waiting list. Is it a significant cost? Can you give us approximate prices if I would be interested in doing that privately, or if I have private insurance? What is the approximate cost?
Well, if you have private insurance, then the cost is very much absorbed according to your level of cover. Unfortunately, to undergo this kind of surgery, to be a fee-paying patient in a private hospital, to have a joint replacement can be very expensive.
All right.
And the variations are maybe how long you will stay in hospital, which hospital you're at, the cost of the implant, so on and so forth. So generally speaking, if you were to have an operation on your hand, you would only maybe be in hospital for 1 day. But actually, if you were to have a joint replacement in your hip or your knee, you would be looking at spending a few more days in hospital. And of course, the bigger implants tend to be slightly more expensive. So there's huge variation depending on exactly.
But for these ones, they're kind of accessible treatments, I would say. Yeah,
they are, and because they're becoming increasingly commonplace, and now people are seeking opinions from specialists. We as surgeons, orthopaedic surgeons, we are all finding ourselves becoming more specialized, and there are fewer people who are generalists. While I was training as an orthopaedic surgeon, I still worked for people who did some hand surgery and some shoulder surgery and some foot surgery and some knee surgery and some spinal surgery, and they were brought up very much as general orthopaedic surgeons. And then I think there has been a progressive trend and a real drift towards creating specialists. And I think that's a good thing. I think it's good for patients.
Because you focus on one thing.
You do, and I think that standards go up when you focus on one particular area. Your knowledge and understanding are a great deal better. And also, because the way medicine has evolved, each particular subspecialty area now is its own universe. There are so many things to know and understand, and there are so many new treatments that perhaps weren't available some time ago. And so it would be practically impossible in the modern age to be a generalist, but still have a deep and detailed knowledge of the knee and the hip and the shoulder and the hand and the spine. And I think that's good all round. It makes good doctors, and I think it's good for patients also.
Indeed. So we have about 5-10 minutes left. What else would you like to tell us which you think is quite helpful to the viewers, or from your experience, other things you observe very common in your clinic and you think it's good to mention?
One thing that I think it would be good to mention are actually fractures and what happens as a result of fractures, and what the philosophy is towards treating injuries and fractures, because especially as we now head towards the winter months.
Yes.
Snow. The snow, the ice, the rain, the darkness. I personally, as a hand specialist or a wrist specialist, see a great number of people who have fallen and they have broken them.
They fall on their hands.
They do, and very typically they fall onto an outstretched wrist. Once again, age and sex have something to do with it, and we know that elderly ladies who are postmenopausal, who have osteoporosis, are the ones who are potentially at most risk. And what may, for a younger person with normal bone, not result in a fracture, may actually result in what we refer to as a fragility fracture in an older person. So something that perhaps seems fairly innocuous, like tripping over on the pavement, or maybe just even a fall at home.
Mechanical falls.
A mechanical fall. And that for an elderly person can be a really dangerous thing.
Indeed.
So one particular group of injuries that I treat are fractures of the radius. So wrist fractures are a very, very common thing. Every hospital will see, you know, many wrist fractures in any given week, but of course in the winter months that's amplified.
True.
So most people, again, in that situation, most people will realise they have sustained a bad injury and they will seek medical attention fairly early. Often they will go to the emergency department and the diagnosis is really made on examination and with an X-ray usually that highlights a fracture.
Usually they have obvious deformity, so you know it's a fracture.
Absolutely. The combination of the history, the fall, the pain, the swelling, the deformity, and then of course the final thing is the X-ray, but you're quite right, you can make your diagnosis well before the X-ray in many cases. So in principle, the first thing that we would want to do is to assess whether or not there are any other injuries. Of course, we get very fixated by broken bones, but especially in the elderly, they may have undiagnosed injuries, maybe to their head or perhaps to the hip. So it's easy to get sort of fooled by a very painful or deformed wrist, but there may be something else going on as well, so it's good to rule that out. Then we have certain ways of looking at an X-ray, and actually in my next slide I have a couple of pictures of some broken wrists, and actually this is a particularly bad wrist fracture, and you can see that the radius in particular is fractured into many pieces, and you can see very clear fracture lines and the bones have moved into an unfavourable position. And so we would take a view on whether or not the displacement of the bones is such that they can be left to heal in that position, and quite often we place people into a plaster and they remain in that plaster for a few weeks. But sometimes we take the view that actually the position of the bones is unfavourable. If the bones were to heal in that position, it would result in a bad wrist or a bad hand.
Loss of functionality mainly? Absolutely,
yeah, because the anatomy of the wrist joint has been in some way changed, and it would potentially lead to dysfunction. So we, again, we have various criteria that we use to try and establish whether or not that those people would be better off with surgery. And what you can see on this particular X-ray is that actually this has been fixed with a very long plate and some screws, and you see that the overall alignment and the length of the radius has been restored, and there is internal fixation that's quite robust and will actually allow the person to start moving their wrist within a matter of days sometimes.
That's very good.
We can use other methods as well, involving wiring. Sometimes we use smooth wires that go through the skin and into the bone, and then they are subsequently removed after the bone has healed in approximately 5 or 6 weeks after the surgery. And they're used in conjunction with a plaster. So overall, again, there's a wide spectrum of things, just like any other thing in the hand and wrist or within orthopaedics. We can manage things very conservatively, but then we move along that scale, and then we intervene surgically if and when we feel we need to.
That's very nice. And can I ask you to make one last comment? I was in a conference, we have the annual GP update course, and I heard something which was very interesting. There was a research started in Scotland, and they decided not to treat osteopenia anymore. And the reason for that was either they would treat or not, people would end up with osteoporosis, or they wouldn't protect them from fractures, especially those with high FRAX score. So they said also, it was a comment from the presenter that would save about £16 billion from NHS not treating. So the bottom line is, don't treat osteopenia, only if you have. Obviously now that doesn't apply mainly to your area of interest. When we will have the next speaker, which comes from the clinic, to discuss about hips, I would be very interested to repeat that question. But generally, as a bone specialist and as an orthopedic doctor, I say it very simply, do you treat these people, and how do you protect your patients who you see in the clinic from these fractures? What is your personal view, if it's easy to respond to that question?
Well, it's very difficult, because unless you screen on a national level for osteoporosis, and then you select the people with osteoporosis, then you treat them for osteoporosis, and then you have an effective treatment for osteoporosis that prevents these fractures happening, it's almost, as you have described, sometimes not worth doing, because the costs of doing it and the practicalities of screening and treating the entire nation with a view to maybe preventing some of these fractures may not be justifiable. It may not necessarily be a practical thing or an efficient thing to do that will really result in improvements for the patients. Most people who I see who have wrist fractures, osteoporotic wrist fractures, never knew they had osteoporosis.
I see.
It's a brand new diagnosis, and of course they turn up with a fracture of the wrist, and sometimes very commonly with a fracture of the hip. And that's their first presentation. That's the first time osteoporosis has, been mentioned to them. And of course we treat the emergency problem, which is the broken hip, for instance, or the broken wrist. And then as a secondary thing, then we will undertake investigations. We will measure their bone density. We will look at them from a metabolic perspective. We will look at other lifestyle factors such as exercise and smoking. We try to reverse those things if we can, sometimes through lifestyle changes, sometimes through medications. But what we want to do is to reduce their overall risk.
And if we have 2 or 3 minutes, I want to ask you something which I forgot earlier about ganglions, which I also see quite commonly, and around the wrist, people have a lot. They say, oh, I have something, my bone is deformed, or something is bulging there. What is that? And we send them for ultrasound, it's ganglion. How do you deal with them? Can you tell us?
Yes.
How often you meet them, and options,
I see them
options?
really, really very commonly. Just to describe what a ganglion is, it's as Kiki has described, it's a lump very classically on the back of the wrist, although sometimes it can occur on the side or the front. But a large ganglion can almost look like a large raised lump, and it can elevate the skin. And first of all, it can become quite unsightly, and people quite often don't like the appearance.
True.
And what it is it's that appearance that normally takes them to see the doctor. So a ganglion is actually a fluid-filled sac, almost like a cyst in some respects, but the fluid-filled cavity has a stalk that communicates with the wrist joint underneath, and actually the fluid that it contains probably arises from the cavity of the wrist joint underneath.
I see.
So for most people it's unsightly, but it can also be really painful, because when they move their wrists back, there is now an impingement on the back of their wrist. The cyst can become squashed and squeezed. They may have a restriction in their range of movement, and quite often they feel that they have pain when they do certain things. Very typical example is whenever they try to push themselves up with an extended wrist, for instance, when pushing up out of a chair, when opening a door, it just recreates pain. And of course that's a really common thing that we do all of the time. We're forever sort of pushing ourselves up off the floor or a chair, or our wrists are extended an awful lot during normal functionality. So the combination of an unsightly lump and a painful impingement leads people to see their doctor. On the whole, if the lump is relatively small and not problematic, just like any other problem in orthopedics, we can choose to leave it. We can choose to not treat it in any way whatsoever because it's a very benign problem. It's not a problem that can become particularly invasive or aggressive, and people can live with ganglions for many, many years without any harm whatsoever.
True.
The next thing that we can think about doing is treating the ganglion by aspirating it, and by that I mean you pop a needle into the lump and you withdraw the fluid.
Ultrasound guided, I suppose?
Well, quite often, if it's a big lump,
if it's a big one, you don't have to.
You can actually just place the needle in the clinic and it's very simple to do. And then you can withdraw this very, very thick, gloopy liquid, almost like a gel, and that comes out of the ganglion. The ganglion goes down very quickly, immediately in fact. But the problem is really that the stalk is still there and the stalk still communicates with the joint underneath. So of course, it fills up, and most people who have an aspiration, a very, very high number, will come back within a few months and it would have recurred. So for a lot of people, I offer them the option of a surgical excision of the ganglion. And so the aim is, yes, to remove the lump, but actually through surgery, you can attack the stalk and divide that right at its very, very base and take measures so that the stalk doesn't reform and then the ganglion doesn't come back. So that's probably the method that's associated with the highest success rate in terms of recurrence. So if you leave it alone, obviously it can go up and down in size and stay there for a long time. If you put a needle in, it's a very high chance it will come back, but it's always, you can think about doing it. But the rate at which it comes back after surgery is still there, maybe about 5–10%, but 90 to 95% of people will have a good outcome.
All right. You see, if we stay longer, I will have more and more questions. It will never end. We'll stay here overnight.
Thank you.
Thank you very much for coming. It's our pleasure and honor to have you here today. Thank you for opening these series of episodes which will follow. Thank you for all the information you gave us. It was extremely clear. You talked very nicely, slowly. I think everyone could understand, even someone who doesn't speak good English. I'm very, very privileged to have this presentation by you today. So I will say good night to our viewers and I hope to see you again soon. Ευχαριστούμε πάρα πολύ που μας παρακολουθήσατε. Ελπίζουμε να βρήκατε αυτή την πολύ ωραία περιγραφή αρκετά κατανοητή και χρήσιμη. Μάθαμε πολλά καινούργια πράγματα και εσείς και εγώ. Ραντεβού σε μία εβδομάδα. Καλό βράδυ.